respiratory tract infection.
I think, thank you, Dr. Arul. Dr. Basavaraja has some important meeting with CIAP, so he has shown his inability for this. So I'm here as a stopgap arrangement. So after a wonderful talk from fever with rash and fever with CNS infection, now we move to our next module. That is a more common, I would say, compared to the previous two, and that is fever with respiratory symptom. And remember that when the child has got this type of respiratory symptom, it is got two important components. One is infection and second is allergy. In this module, we are going to deal with only infection. We are not going to deal with allergy. So the child may have got the nasal symptom, child may have got rhinitis, runny nose, or nasal itching, more common with the allergy. There may be some nasal discharge, it may be a purulent or non-purulent, or child may have predominantly cough, child may have got the breathing difficulty, rapid breathing, or tachypnea, or there may be some other problem like ear problem, or stridor, or croup-like syndrome. So these are the common symptomatology with which the child with respiratory infection will present to us along with fever. So we have got the fever with nasal symptom, we have got the fever with cough, we can have a fever with rapid breathing, and we can have a fever with ear problems. Now, out of this, the upper respiratory infection are most common. Nearly 60 to 70% of all the respiratory infection belong to upper respiratory infection, and majority of them, they are viral, and they will usually have a fever, cough, nasal discharge with or without involvement of the ear, that is otitis media. Sometimes they may have a lower respiratory infection, they are less common compared to upper respiratory infection, and they will usually have a fever, cough, and rapid breathing. When cough is a predominant feature, it's an airway disease. When there is a difficulty in breathing, usually it indicates that the child may have got some alveolar or the parenchymal involvement. As far as the upper respiratory infection is common, the commonest one we have got the tonsillopharyngitis, otitis media, and sinusitis. As far as lower respiratory infection is concerned, we all know it commonly includes bronchiolitis, with associated viral infection, or it can be a pneumonia. However, in some of the situations where both upper respiratory and lower respiratory both are involved, which includes the condition like pertussis, acute laryngotracheal bronchitis, diphtheria, even flu can have a involvement both upper as well as the lower airways. Now, like any other in fact, where any other system, we can also have some localizing anatomy in the respiratory system as well, which will tell us which part of the respiratory system is affected. You know, we have got the upper respiratory and the lower respiratory. In the lower respiratory, we have got the lung parenchyma, bronchus, even pleura. So it is a localization will be very, very important, and it all depend upon the sign and symptom with which the child is presenting. Suppose if there is an airway disease, airways are affected, then cough is a predominant disease, a predominant symptom, and usually the signs are generalized. In case of upper airway, when upper airway is affected, the cough is present, but the character of the cough will be a dry, hacking cough. Sometimes it is associated with the hoarseness of the cough, hoarseness of the voice. There may be stridor, and when stridor and hoarseness are there, usually it indicates that there is a upper airway involvement, and sometimes there may be a suprasternal retraction. So when there is the chest retraction are there, which is mainly suprasternal, it indicates that upper airway is affected. In case of the lower airway, again, a cough is a predominant feature, but here the wet cough will be more. Child may have got the tachypnea, wheezing, and instead of the suprasternal retraction, we have got the subcostal retraction. So a subcostal retraction is a sign of the lower airway, especially the large airway. Sometimes the lower small airways are affected, where here the patient will have a cough and tachypnea, but here the tachypnea will be more than the cough, and the chest retraction are also present. As far as the lung parenchyma is concerned, cough is not a predominant feature, but on the contrary, child will have a grunt. There may be an intercostal retraction. So the child will have a retraction, but it's an intercostal retraction, and sometimes the open localized sign will be there. The child may have got the bronchial breathing or a localized crepitation. So remember that grunt is nothing but a natural CPAP. So this is the involvement of the lung parenchyma. When pleura is affected, usually the pain is the important feature. The child will have a chest pain, there will be tachypnea. However, there may not be chest retraction. And the pain, there may be a localized pain or a localized sign depending upon the pleural distribution of the clinical sign. When the interstitium is affected, it presents like mainly presents the mild cough, there will be tachypnea, and there will be more generalized signs. And usually, the child will have a inability to maintain the saturation at room air. So, hypoxia is one of the cardinal signs as far as the interstitial lung disorders are concerned. However, there may be a combination of disorder. May the child may have got the upper and lower airway affected. There may be a parenchyma and pleural involvement is there, and there may be involvement of the interstitium along with the parenchymal disorder. So the combination disorder there, and when the combination disorder is there, child may have a generalized airway disease. There may be involvement of the lung, or there may be a interstitium, and this generalized involvement of airway, lung parenchyma, and interstitium is classically seen in case of the viral infection. As well as the localized infection are there, localized disorder is there, then usually it indicates a pleuroparenchymal involvement, and usually you have to think of a bacterial infection. So with this basic, let us move quickly to the case. A 30-month-old boy has a typical viral prodrome in form of the fever, cough, and cold for 2 days duration. Child also started to have a rapid breathing since last 1 day. There was associated redness of the eye. Temperature was 101 degree. Saturation was 94 at room temperature. However, there was recent outbreak of the H1N1 in the community and treated as a case of wheeze-associated lower respiratory infection. So here we see that the child has got a viral prodrome. There are a number of there was recent outbreak in the H1N1. There was redness of the eye. So multiple mucous membranes are affected. So probably we are dealing with a case of virus infection, and that was treated as a case of well-developed antibiotic and a cough cold mixture and nebulizer as an OPD case. But surprisingly, there was sudden deterioration, and child was brought in the emergency. And when the X-ray was done, it was a very bad X-ray, and child was maintaining oxygen about 94, 93 after 7 liters of the oxygen. And so there is a sudden, so there is a viral prodromal picture. There is an epidemiological setting for the H1N1 in the recent past, and there is a sudden deterioration. So what we are dealing with? So probably here we are dealing with a case of an influenza. So when to suspect influenza? Number one is an epidemiological background. The history of contact, history of the contact or epidemiological similar cases or the notified outbreak in the community is one of the strong criteria which helps us to diagnose clinically a case of influenza. Secondly, the symptoms are always there, that is myalgia and headache and fever. They are more pronounced and more common, and this helps us to differentiate that we are not dealing with a case of simple common rhinosinusitis or a common cold. Number three, that there may be a respiratory manifestation which involves both upper airway as well as lower airway. And number four, child may present directly as a case of croup, bronchiolitis, or even pneumonia. Out of this, pneumonia is the commonest presentation as far as H1N1 is concerned. And last one, sometimes child may have the complication in the form of pneumonia, that is post-viral pneumonia, myocarditis, encephalitis, or even Guillain-Barré syndrome. Out of this, the most important thing there should be an unusual course of any viral respiratory infection is there, then you have to suspect of H1N1. So remember, friend, when a child has got the common cold like symptom, but it does not behave like a common cold, means the fever is out of proportion to the duration of the illness. If there is marked frustration, marked weakness, if there is myalgia, if there is headache, if there is sudden deterioration, usually the common cold will subside by day 5 or day 7. But if there is initial improvement and then again there is deterioration, or if there is an unusual lengthy course, then if the epidemiological background is there especially, then you have to suspect a case that probably you may be dealing with a case of influenza. Now, it is very important for all of us to know, sense that how will you differentiate between common cold and flu. So as far as the flu is concerned, fever is very, very high grade, 100 to 104, and may last for 3 to 4 days, where fever is mild to moderate in case of common cold. Headache is prominent. Fatigue, weakness is very common, often severe. There is generalized aches, pains, which may persist for 2 to 3 weeks, but these symptoms are going to be absent or mild or slight, or they are mild in case of common cold. The extreme exhaustion is early and more prominent feature of a flu, which is not there in a case of cold. Stuffy nose and sneezing and sore throat are usually more common with a common cold, but they can sometimes occur in a case of H1 as well. And chest discomfort, breathing difficulty are more common and can be even severe in a case of flu, but it is only mild to moderate hacking cough with some runny nose is common with the cold. Sometimes the influenza can present with a croup, bronchiolitis, pneumonia, febrile illness mimicking bacterial sepsis, and sometimes it can predispose to a bacterial infection like a post-viral otitis media, bacterial otitis media, pneumonia, or sometimes it may have got the bronchiolitis like of the presentation. Now then, the question next question is when we suspect a flu, when will you start oseltamivir? Should we wait for the investigation? So answer is no. So during an epidemic or outbreak situation, only clinical decision is suspicion is sufficient to start the oseltamivir. So do not wait for the laboratory confirmation because the microbial diagnosis is required only in severe admitted cases. If you start the oseltamivir within 48 hours, then and then it will help. Then we will get the response. So treatment started early in the course, that is within 48 hours, will help to reduce the disease severity, complication, as well as mortality. If you start oseltamivir late, there is no use of it. The treatment after 48 hours is recommended only for the hospitalized, complicated, and serious cases who has got the progressive illness. So friends, the common answer is that straightway start the oseltamivir once you suspect it, especially when there is a clinical suspicion is there or when there is an epidemic situation is there. Laboratory investigation are required only in the hospitalized cases, and there is no role of the chemotherapy unless you have got the immunocompromised child or a child who has got a comorbid situation. So that is about the flu. Now there is another case number two. A 2-year-old male child is vaccinated at the urban health center. Weight is 8.1 kg. There is an acute illness of fever and difficulty breathing of 1 to 2 days. On the previous night, child has vomiting. There was mild cough, and the child is not taking food well. So here there is fever, not taking fever, and difficulty in breathing. So we are dealing with a child who has got the fever with rapid breathing. Mostly it seems to be a case of bacterial infection. On examination, child was febrile, ill looking. There was tachycardia was there, tachypnea was there, intercostal retractions are there, and there was bilateral crepitation with bronchial breathing at the right midzone. And so clinical diagnosis was right midzone pneumonia. And as the child is not able to drink, not able to take well, and there was tachypnea over there, it was diagnosed as a case of severe pneumonia. So next question comes, how will you assess the severity in a case of community acquired pneumonia? So now we have got the new WHO classification, and it has only 2 categories. Previously, we were having 4 categories. Now we have got only 2 categories, and it includes that. And there are two categories. One, that is pneumonia. Any child who has got the fast breathing and or chest indrawing. As a severe pneumonia means the child who has got pneumonia with any of the general danger sign. And the danger sign which includes a grunt, not able to drink, persistent vomiting, convulsion, lethargy, unconsciousness, cyanosis, presence of apneic spell, especially in a young infant or a narrow pulse. So these are the situations which indicate a danger sign. So when the danger sign is present, we are dealing with a severe pneumonia. And if there is just danger signs is absent, but fast breathing is there, then we call it a simple case of pneumonia. Now, which cases require investigation? So friends, the investigation are required only in very, very limited cases. In most of the time, in a commonly acquired pneumonia, investigation are not required. What is required is a clinical evaluation and the pulse oximetry. And this pulse oximetry and this clinical evaluation is a good tool for assessing the severity as well as for the monitoring of the response to the therapy. We usually end up in doing CBC and CRP, but they are not much of the diagnostic help, but sometimes may be useful to monitor the response to the antibiotic therapy. X-ray test, again, we usually do it in our day-to-day practice. But usually, ideally, it is not recommended, but it is a must if we are dealing with a case of complication like development of pleural effusion, or if the child is not responding to a case of pneumonia. And last one, USG is an important tool, especially when we are suspecting that the child is developing pleural effusion. So in general, as clinical evaluation, pulse oximetry, at the most CBC, CRP, X-ray chest, and USG in a suspected pleural infection are all that is required in a case of investigation. When we did our investigation, in our case, you can see that there is a classical case of pneumonia. You can see this cotton wool exudate. Hemoglobin was low. Total count was 10,600. Poli 68%, and CRP was high, that is 32%. So we are dealing with a case of a commonly occurred severe pneumonia, and therefore we need to start the antibiotic. But before starting the antibiotic, we need to find out which type of the bug we are dealing with. And for that, determining the bug, the most important criteria that is to be considered is the age of the patient. So if the child is less than 3 months, gram-negative organism, Streptococcus pyogenes, viruses, and sometimes uncommonly chlamydia trachomatis should be considered. If the child is 3 months to 5 years, like in this case, of course, viruses are always there, which constitute about 35% of cases, but other organisms, Streptococcus pneumoniae, HP, Streptococcus pyogenes, and Mycoplasma. Out of this now, pentavalent vaccine is available in our national program, so he is becoming less and less common. Remember that Mycoplasma pneumoniae can occur even in a child who is even less than 5 years of the age. And as the age advances, again the viruses become less. Virus is the commonest one, but again it is followed by Streptococcus pneumoniae, Mycoplasma, Staph, and pyrogens. Viruses are little lower in the down. So here in the more than 5 years, I would consider Streptococcus pneumoniae, micro. So it all the age group beyond neuro period, it is the Streptococcus pneumoniae, which is the commonest organism that we come in our day-to-day practice. And for that, we need to select a right drug for the right bug. There are certain clinical clues, and further, a thorough clinical history and examination is very, very important. Suppose a child who has got the pyoderma and history of measles in the recent past, you have to think of the organism like Staphylococcus. Immunocompromised like HIV, there may be some infection because of the pneumocystitis. If there is febrile neutropenia, they are more prone to pneumonia caused by gram-negative organism and fungus like Aspergillus. Cystic fibrosis, the Pseudomonas, Staphylococcus, Acinetobacter, and Burkholderia are considered as a signature organism as far as the pneumonia is concerned in a case of cystic fibrosis as a cause of bronchiectasis. If the child has a severe proteinuria malnutrition or SAM, a gram-negative organism, staph, is very common. Unconscious child, neural condition where the aspiration is common, anaerobes are very common. Febrile infant with conjunctivitis with typical staccato cough is there, with chlamydia is common. Pneumonia with lymphadenopathy, tuberculosis, and sudden onset, sudden deterioration, and outbreak situation, you have to think of the influenza and the current pandemic like a COVID is also there, where there is sudden deterioration is common. Now, once this is established, then how will you, which tests are required for the microbial etiology? Mind you friends that microbial diagnosis is not required in all cases. They are required in only very, very selective cases, especially we are dealing with a complicated case, prolonged hospitalization in the ICU patient in an immunocompromised child or in an outbreak situation, then these are required. Whenever they are required, of course, the small subset of these children are there, then which are the investigators which help us to find out to come at a microbial diagnosis. So among them is a blood culture. Second is a sputum, gram stain, and culture. If pleural empyema or fluid collection is there, you have to examine the pleural fluid for the gram stain and culture. Serological tests are especially useful for mycoplasma and chlamydia. Now we have got the antigen agglutination test is available for the pneumococcus, which can be done both in the urine as well as in the pleural fluid. For the viruses, we have got the molecular test. Now we have got the biofire respiratory panel is also available. Lung puncture is invasive and usually not asked to. So out of this, the blood culture, the I think the bacteremic illness is less common, which we are dealing with a mucosal illness, and therefore the blood culture yield is not going to be that high, but it is always recommended in all hospital cases where you are going to start the antibiotic. Other rest, the sputum, gram stain, pleural fluid, only required only in case of the empyema. Rest of the tests are not routinely done and subjected only to a very selective cases. Now, as I said, that these tests are not done routinely, but especially they are required for some of the indoor cases. I've already told you. So in an immunocompromised child, pneumonia with a comorbid situation, pneumonia which are not responding, difficult nosocomial, necrotizing pneumonia, pneumonia with complication, and in outbreak situation, some of the investigations are required on one individual cases. Now, Once we have diagnosed a case of community pneumonia, how will you manage it? The most important thing is a stabilization is the most important, and it includes airway, breathing, and circulation. Remember that the patient of pneumonia is going to die of hypoxia. So no amount of any antibiotic is going to work unless you take care of the airway, breathing, and circulation. So stabilization, control of the fever, which will reduce the metabolic rate, which will reduce the work of breathing, is also important. And equally important is the institution of the first dose of the antibiotic. And if you look at the choice of antibiotic, if the child is less than 3 months, always consider it as a severe pneumonia, always treat as an indoor patient. But if the child is more than 3 to 5 months, may be treated as outdoor patient or indoor patient, depending on the severity of the illness. In a less than 3 months of the child, the drug of choice is a third generation cephalosporin with or without aminoglycoside. From 3 months to 5 years, it is amoxicillin, or at the most, you give amoxicillin. Do not just jump onto ceftriaxone and cefotaxime is a second line of drug. Similarly, more than 5 years, amoxicillin is a drug is fair enough. Macrolide can be given if mycoplasma is suspected, or if there is a no response to amoxicillin, you can add macrolide in that case. But because the child has got the age more than 5 years, do not directly jump to macrolide. Do not add or do not jump to azithromycin or clarithromycin. First line remains, here also remains only amoxicillin as well. And here again, the second line is ceftriaxone and cefotaxime with or without macrolide. As when we talk of the staph, remember that methicillin saturated staph aureus is more common. Though we have got the increased incidence of MRSA in the tune of 25 to 30%, again, all staph does not warrant the use of vancomycin or linezolid. It is a reserved drug, only should be given in a suspected MRSA cases, or when the child is moribundly severe or very much sick. What we need is to cover MSSA, and cefazolin is good enough. Cloxacillin is best drug, may not be available every time, and therefore you can give either cefazolin with sometimes we may add aminoglycoside. Another drug which is more often forgot is a clindamycin, which will take care of the toxin associated with staphylococcal infection. As far as the outpatient antibiotic is concerned, if the child from 3 months to 5 years, amoxicillin, or you can give amoxiclav or cefpiroxime as a second line drug. If the child is more than 5 years, again, amoxicillin remains the drug of choice. Macrolide, coamoxiclav, and cefpiroxime are again a second line of drug. In less than 3 months, always treat as an inpatient. And when you are using amoxicillin in India, the dose is 40 milligram per kg. Remember, 80 mg per kg is required for the Western world, where there is high incidence of the penicillin resistance. So in India, still it is 40 mg per kg. In WHO recommendation is 80 mg is there, but WHO does not make a country-specific recommendation. We have got the non-meningitis strain of Streptococcus pneumoniae, which is still sensitive to amoxicillin, and 40 mg per kg is good enough as far as our Indian country is concerned. So now, friends, when to suspect mycoplasma? So we have got the clinically a child more than 5 years. Child is not ill looking. That's why we often call this is called as a walking pneumonia. Child is totally comfortable, and in spite of its a bacterial infection, the features are like a viral infection. Means child will predominantly will be a cough. There may be a myalgia. There may be multisystem involvement. There will be interstitial pneumonia, and sometimes child may have got the extrapulmonary manifestation either in the form of anemia or erythema multiforme, or sometimes the child may have got the encephalitis or encephalopathy like picture. So whenever the child is more than 5 years, you suspect mycoplasma. But I told you, mycoplasma can be severe. Mycoplasma can occur in a child less than 5 years, and more cases are now coming that in a younger male less than 5 years with complication, we often see mycoplasma nowadays. And this is mainly because of the development of the commonly acquired respiratory distress syndrome toxin, CARS toxin, and they are responsible for both extrapulmonary and pulmonary manifestation. So this pulmonary manifestation may be because of a direct infection, but some of the pulmonary manifestation, extrapulmonary manifestation, is because of the post-infective immunological phenomena induced by this toxin. As far as test of mycoplasma, no, nothing is gold standard. We can use a nasopharyngeal swab PCR, serum IgM by ELISA, cold agglutination, and clinical background. So all these three have their own merits and demerits. I'm not going to detail of it, but what is more required is a clinical background is the most important. So a positive swab may have a carrier stage, or may have got a real disease itself. And therefore, it is very, very important that a clinical background or clinical correlation is very, very important. As far as cold agglutinin is concerned, it is overused and more, I would say, higher titers are required are required to clinch the diagnosis. So a low titer cold agglutinin positive has nothing to do. And again, here in this case, clinical correlation is very, very important as far as mycoplasma is concerned. Now, get where the wonderful tool that is a BioFire respiratory panel, which detects 21 pathogens in 45 minutes. But probably we should be away from this type of the routine recommendation as done in some of the corporates. So it is only subjected to a very selected cases and does not require in all the cases. As far as the staff is concerned, there may be a past history of the pyoderma in the recent past. There may be a history of measles or chickenpox in the recent past. It is more common in the malnourished child, and the X-ray is typical tissue breakdown giving rise to pneumococcal is very, very common. And sometimes there is rapid progression. The lesion go on changing and improve fast, and there is rapid progression to pneumococcal, pneumothorax, sometimes empyema, and sometimes pneumothorax. So if there is rapid progression is there, you have to think of the some invasive staphylococcal infection. Now, once you have started a correct antibiotic as per the recommendation, in 72 hours there is no response. So, which are the kind of situation that you have to think about when there is no response? So, first and commonest thing that we think that with the commonly acquired pneumonia does not respond to a good antibiotic as per the recommendation in a perfect dose with a perfect dosing interval, then you would think of the complication, and common complication we encounter in our practice is empyema, and second is a lung abscess. The lung abscess is nothing but an extensive form of a necrotizing pneumonia. Second thing, the antibiotic or the drug that you have been chosen may not be applicable aptly for a underlying organism. So it may be a different pathogen. You may not have thought of it. So probably you may be dealing with a case of tuberculosis or a mycoplasma. And third one, there may be an issue of drug resistance, like commonly acquired MRS is rising, nearly 20-30% cases. And now we have got the drug resistant Staphylococcus pneumoniae in the Western world as well. So out of this, the common situation that we come in our day-to-day practice would be empyema, tuberculosis, and CMRSA. Uncommonly, we can say less commonly, we can have abscess and mycoplasma. DRSP is not there. One of the important common situation that we encounter is a foreign body aspiration, a forgotten foreign body which is sitting under beneath. Sometimes will not allow the pneumonia to resolve. So foreign body is one of the important cause that we have to think of. So the commonest cause among this is a development of the empyema. So let us now discuss how will you manage a case of empyema. So once the empyema is there, you must be diagnosed from clinical examination, from X-ray, or from the USC. And for that, after once empyema is there, the fluid must be drained out. Unless you drain the fluid, no amount of antibiotic is going to work. So this fluid is very, very important. So whatever the fluid is you obtained or aspirated must be sent for the examination. Along with you have to continue your antibiotic, and sometimes and surgical intervention are required. The common tests that are performed the pleural fluid are the routine examination. Always send it for the culture. Always send it for the gram stain organism. ZN stain is required in a suspected tuberculosis. Again, like CSF, ADA has not much been useful and should not be resorted to. And when a TB is suspected, we have got a very good tool now, CBNet, and we have to do the CBNet upfront in a suspect case of tuberculosis. So that these are the common incidents with investigation which are required in a case of pleural effusion. Now, sometimes we go for the CT chest, but this CT chest has again a very limited scope. Again, all the cases should not be sent for the CT because of the high risk, high cost, and the high radiation hazard. And therefore, it is required only in selected cases, especially when you are suspecting a peel in an organized empyema, or when there is suspicion that you are dealing with a case of bronchopulmonary fistula, then CT has a definite role. Sometimes it is done as a routinely as an investigation of a non-resolving pneumonia or a recurrent pneumonia. Sometimes you may do a CT to find out it is a diagnosis. In a workup for the necrotic pneumonia or a necrotic lymph node in the mediastinum, CT is required. And sometimes nothing is there. Sometimes we have a lymph node biopsy. So CT guided biopsy in the mediastinum can be done with the help of CT. So CT has a definite role, but again, they are required in very small subset of selected cases, and all cases should not be subject to the CT scan. The most important message I want to say that a good USG is better to explore the septa and localization in a case of empyema. So good CT is very, very important, is more sensitive and more it provides and gives more as far as the localization and septa identification is concerned. Whereas if we find bronchopulmonary suspects some fistula or a pill, in that case, probably CT has a definite role. So as far as the empyema management is concerned, different modalities are available. Of course, you have to continue the proper antibiotic, but along with antibiotic, what is required will depend upon the age or the stage of the empyema. If there is a duration of empyema is less than 5 days, you continue with intercostal tube drainage with antibiotic. If there is no response in 72 hours, consider either VETs or fibrinolytics. In our center, we do not use fibrinolytics. We directly go for the VETs. As far as the 5 to 14 days concerned, again, you have to repeat the USC, look at the localization and consider VETs or ICD as per the localization. If the localizations are more, probably VETs will be much helpful. And if it is more than 2 weeks, do go for the CECT, assess the pill, and if pill is present, then probably your VETs is not going to work. And this is the ideal case where the decortication is required. So the modality of the treatment will depend stage of the empyema. Only thin fluid, small amount fluid, only antibiotic. If there is a tappable fluid, then ICT with antibiotic. And if it is not working, then VETs with or without fibrinolytic. And if peel is present, then decortication is required. So that is all about the management of empyema is concerned. And sometimes there is a pneumonia patient is not getting better, then you have to consider that basic, whether the diagnosis is correct or not. If diagnosis is correct, whatever you treat is adequate, not very important. So for that, antibiotic in an adequate dose is a must. So inadequate or improper treatment is the commonest cause as per the failure or the non-response to the pneumonia is concerned. Once the antibiotic factor has been taken care, you have given the antibiotic correctly in a correct dose, then you have to think of a complication like empyema or the lung abscess. If this complication is ruled out, you think of the two important things. Probably you may be dealing with a different bug like mycoplasma tuberculosis, or there may be an issue of the drug resistance like MRSA or DRSP or MDR tuberculosis. If all these factors have been taken care of, then you think of the non-bacterial cause, and probably these are the situations where imaging and bronchoscopy are going to be helpful. And these are the situations which require, which needs to be attended is to rule out bronchial obstruction, endobronchial lesion, and foreign body. If this is also not there, then sometimes host factors are there. Host may be at fault. There may be a immunodeficient child, and we have to find out a condition like HIV or a cystic fibrosis or asplenia or functional asplenia or splenectomized child where the pneumonia is not going to resolve that good. And sometimes you may be dealing with a case of non-respiratory cause as a cause of non-resolving pneumonia. So that is about the child when pneumonia is not getting better. So with this, I thank all of you for your patient hearing, and I'm thankful once again to the IIP Chennai, IIP Tamil Nadu, IIP Madurai, and Pondicherry branches. Thank you so much.
Thank you, sir. We move on to the last topic for today's discussion, fever with lymphadenopathy. To highlight on this topic, I request our respected speaker, Dr. K. Muthukumar, Professor of Pediatrics, SRM Medical College, Trichy. Sir is currently the Central Executive Board member 2020 and also the past president of Tamil Nadu State Chapter and a renowned speaker. Over to you, sir. Dr. K. Muthukumar.